Welcome to the webinar series today on rethinking posterior tibial tendinopathy. And this is a disease process that is extremely common. And unfortunately, most people have to wait until their foot is almost completely collapsed before they have a real treatment, a real surgical option given to them. And so anyway, what I've done is reviewed the literature, and I want to give you a different perspective and on posterior tibial tendinopathy. So the first question we have to ask is, why is it that a healthy tendon becomes diseased? Because in childhood, nobody ever is born with a diseased posterior tibialis tendon. It's something that is developmental. It happens as we grow older. And we know that there is basically one section of the tendon that repeatedly, from patient to patient, is diseased. So proximal to this area, the tendon is healthy, and distal to that area, it's also healthy. So, so we need to question why that is. And then we want to look at the treatments. Does this look like a treatment that you'd like to have done to you, or that you would perform to a family member? Or maybe there's something that we can do prior to this so that we can actually prevent something like this from happening. So it's time to consider the treatment protocols and look at it from a new beginning. So first off, what exactly is the function of the tibialis posterior muscle tendon unit? And that's something that's important, is that we have to think about not just the tendon, but the muscle and tendon combination. I think that this is kind of a problem where we only think about the tendon part of that, and we're only trying to address that part of the disease process. So the function of this, going into the physiology of it, is that it is a dynamic stabilizer of the medial longitudinal column of the foot during the stance phase of the gait cycle. So basically, it's supporting the medial column of foot bones versus the lateral column. Now, something else is that it is an anti-pronator muscle. So it resists pronation at the beginning of heel contact. So right when that heel is touching the ground, the central nervous system is already sending a signal to the muscle so that it can contract in order to prevent excessive pronation from occurring. So after a heel strike, it's going to actively contract, and then it's going to contribute to supination of the subtalar joint just prior to heel lift. And then the foot goes on to the swing phase. So it is a primary supinator of the subtalar joint in the late stage of the gait cycle. So another thing that we have to look at is the insertion of the posterior tibial tendon into the plantar aspect of the foot. Now, there's been a lot of anatomic studies done on this, and there's a big variety of insertions. Not everybody has the same pattern, but overall, this is what we have, is that the majority of the tendon inserts into the plantar aspect of the navicular, and then it's into the medial intermediate cuneiform, bases of the metatarsals, and then there's a slip that even goes to the sustentaculum tali. Again, all on the plantar aspect of the foot, and kind of more medial than lateral. Now, once the muscle contracts, it's going to create energy. And that's how we have how the muscle helps to lift the foot up during the later part of the gait cycle. So there's a dynamic source of energy that's produced actually within the tendon fibers themselves. So there's going to be a strain on the tendon that produces that stretch, and then that stretch is going to release the energy, and that's what helps to supinate the foot. So we have an energy recycler. So again, it's kind of like a spring that's in your foot, where it's going to recoil and uncoil. So we're going to dive into this a lot more in a little bit. So again, so we're looking at the muscle tendon unit is lengthened during the early full foot contact, and that's what is then trying to resist the foot pronation. And so all of that stretch is absorbed within the elastic tissue of the tendon until it's released when it's supinating the foot. And so I want to kind of like jump ahead here, but so there's a specific amount of energy that is going to be normal of the coil and recoiling of the forces acting on the tendon themselves. So just as long as those forces maintain within this normal limit, then the tendon will function really virtually forever. And that's why not every single person ends up with posterior tibial tendon disease, because they have a normal amount of strain on the tendon. So there is this critical threshold that if the forces reach above that, then that's where we're going to have an excessive force acting on the tendon, and that's going to then eventually lead to tendon pathology if nothing's done to normalize those forces. So we can see here that how this force has gone above the critical threshold, and eventually, if nothing's done to fix this, to restore the efficiency of the tendon, it's going to become diseased. So let's think about how this muscle tendon unit is functioning with its insertions into the plantar aspect of the foot. So when the foot is in the air during the swing phase of the gait cycle, the tendon has no stretch on it. But then once the foot is weight bearing, the person is weight bearing, then that's when we're going to have a specific amount of strain that's placed on the tendon. And so we have the two phases where the tendon is elongated, and then where it recoils and helps to supinate the subtalar joint. So during that early phase, when the talus is pronating, the tendon is pulling up on the navicular to try to prevent that excessive pronatory force. Okay, so that's, a lot of us don't really think about that part of the physiology of the tendon. And I love having these graphics here to really help to show when this coiling and recoiling is occurring. So we have it right here at the early part of, right after heel strike, and then the energy is going to be absorbed during the mid portion of full foot contact. So here we have the initial strain that's going to counter and slow pronation. Energy is created, and then it's going to be absorbed and stored within the tendon itself. And then later on, once the subtalar joint gets back into a supinated position, it's going to help supinate, bring that talus from the pronated position, neutral position, and back into the supinated position. And then the rest of the time, there should be really no strain on the tendon itself. So it's occurring right in there. So when people have a normal, stable, aligned subtalar joint, there's going to be just a healthy amount of elongation of the tendon, and it's only going to be a few millimeters at most. And so again, that's what the tendon is designed for. So when we think about the anatomy and the histology of tendons, we're going to see that they have this wave within the fibers, and that wave is there to help to absorb that strain on the tendon. So that is that spring. But what happens with people with the chronic tendinopathy is that we see that there is such a disease process that's occurring within the fibers. So they've lost their ability to have that springiness. It's like the spring that has been overstretched, and now it loses its normal function. Now, when it comes to posterior tibial tendinopathy, when surgeons go in and cut out that diseased portion of the tendon and they send it off for pathological analysis, what we find out is that there actually is not a tendinitis. There's not an inflammatory reaction with the tendon. What we actually see is a degenerative process where the tendon is just overstretched and it's very unhealthy. It is diseased, but without the signs of an active inflammatory process. And then what we find is that there is fibrosis within the tendon. And that tells us that there is a chronicity of micro trauma repeatedly acting at the specific course along the tendon. And that's that watershed area that is always referred to in textbooks and in lectures. And that's always where we can predict that when we get an MRI or when we open up the foot, that specific area is where the diseased tendon is occurring. Now, there's a theory out there that says that it's first, you have a normal, healthy foot structure, that the bones are aligned and that there's no problem, and that somehow then the tendon becomes diseased, and it's because specifically that the posterior tibial tendon is diseased and it gets overstretched, that's what leads to this adult acquired flat foot. Of course, that doesn't make any sense whatsoever. This is kind of the chicken and egg theory. And so unfortunately, so many surgeons are out there saying that it's the posterior tib that failed and then the foot collapsed. Well, the literature, common sense kind of argues with that anyway, but the literature proves that if you go in with a healthy foot structure and you cut the tibialis posterior tendon, that there's absolutely no change in the foot structure. So somebody has to already have a weakened foot structure in order for the strain to occur on the posterior tibial tendon. So when we take a look at this foot here, this is a stable hind foot, and what determines the stability of the foot is first the articular facets between the talus and the calcaneus, and then you have all of the vast network of ligaments from the tibia and fibula to the talus, from the calcaneus to the talus, and then the navicular and cuboid to the talus. So all of those ligaments are very strong and help to support the subtalar joint. So if we would just go in and cut the tibialis posterior tendon, that's going to have a negative effect, but it's not going to cause then the talus to partially dislocate on the calcaneus, leading to a flat foot. Here's another paper too that was published in 2016 that showed that when you go in and repair the posterior tib tendon, that it does not recreate the integrity of the medial longitudinal arch, so that the subtalar joint is still subluxing under weight bearing. And that pretty much makes sense, because we know that if you go in and only have a soft tissue repair of a diseased posterior tibial tendon, it's not going to last long. Patients initially have a pretty good recovery because they've been non-weight bearing, and the new tendon is going to heal and be kind of strong, but we still have the same underlying etiology that caused the tendon to become diseased in the first place. So pretty much it's like putting a new tire on your car without balancing that tire, and eventually that tire is going to wear out and you're going to need another tire. So there's been a lot of controversy that, unnecessarily, really, in my opinion, about what is the source of the repeated microtrauma to the posterior tibial tendon. Some arguments have tried to be made that it's a vascular issue with the tendon, but again, there's that strain that comes first, and with the strain leads to vasoconstriction of the blood vessels that are trying to feed nutrients and to remove the metabolites from the tendon. So if we're not getting that waste material from normal tendon function removed, then we're just ending up with this mess of toxic tissue that's going to lead to further degeneration of the posterior tib tendon in that watershed area. So what do we know about risk factors for people that have posterior tibial tendonitis or tendinopathy? First thing is that they're women, more common than men, and they're middle-aged, usually over 50 or above. We don't really see posterior tib dysfunction in patients below 40 years of age. Usually it's much older than that. And it progressively gets worse with increasing age. The majority of people, if not all of them, have a lower than normal arch. And there's usually some comorbidities that have been determined with high blood pressure and diabetes. And a lot of people have had steroid injections. Now, giving a steroid injection to somebody with posterior tib dysfunction is a contraindication, because that steroid is there to treat an inflammatory reaction that does not exist. And it's been known that those injections lead to further degeneration. And why that happens is because there's always an anesthetic that's given with the injection that knocks out the pain. And so then the patients are able to go and they become more active with a faulty foot structure, which then just puts more strain on the tendon, and then it leads to more tendon damage. So what is the forecast with somebody when they come in with a stage 1 posterior tibial tendinopathy? Well, we know that without effective treatment, it's only going to get worse, because you can give them all kinds of conservative care, but with every step that they take, they still have excessive forces acting on the tendon. So if we don't get rid of the underlying etiology, of course, the pathology is going to get progressively worse. So what do we see? A stage 1 goes to a stage 2, 3, and 4. And it's just an accident waiting to happen. So there is 100% proven etiology that lowering of the medial longitudinal arch combined with a partially dislocating talus on the calcaneus, the subluxation of the subtalar joint, leads to posterior tibial tendinopathy. So this is nothing new. This is not revolutionary, and it makes obvious sense because number one, if you have a hyperpronating foot and you have a muscle tendon unit that's trying to prevent that excessive hyperpronation, well, it's a losing battle because the tendon cannot overcome the osseous forces, that weight-bearing force of the talus partially dislocating off of the calcaneus. It just can't. So with every step that's taken, more and more damage is being done. So we know that there's already, again, a lot of literature out there and a lot of studies have shown why healthy tendons become disease. And it's because of that mechanical overuse. There should be absolutely no mystery for any surgeon out there as to why somebody develops posterior tibial tendinopathy. So we have this mechanical overuse that is repetitive, and we have excessive loading that leads to a muscle imbalance, misalignment, and then from there we have aging issues, hormonal. That's kind of why women have more of a prevalence for this than men. And of course, there's other things that happen too with extrinsic factors of your normal health or abnormal healthy lifestyle. But then what ends up happening is that little by little, we get this reactive tendinopathy and it just becomes diseased until we end up with that partial tear. And now we're in a really bad situation. So it's just little by little getting worse and worse. So why is it that, again, this is why does this first develop? I mean, this is not a congenital problem, or I guess actually you could even say that it is because you're predisposed of developing posterior tibial tendinopathy when you have that pediatric flat foot. So this is yet another situation where it is important that we identify pediatric flat feet, more specifically recurrent talotarsal joint dislocation, and to understand that this is a disease entity that is going to lead to many secondary pathologies. So think about this. Right now, if we went in and cut out the posterior tib tendon, we're going to know that it's healthy. There's not going to be any inflammatory reaction. There's not going to be any disease because the patient, this is a young person, so they haven't lived long enough yet and they haven't taken enough steps for that tendon to become diseased. But just think about what's happening here. Think about the plantar fascia. Think about the pull and the strain on the calcaneal apophysis and even the Achilles tendon, how it's being overstretched. But so the main deformity is when that talus slides forward and it drops the navicular, that's going to increase the strain on the posterior tibial tendon right there. So think about this now later on when this person's 50 years of age and how with every single step that they've taken, that more and more of that tendon is being overstretched until it just can't take it anymore. So what is the current treatment pathway when somebody comes in with posterior tib issues? Well, a lot of surgeons are going to, or physicians treat this as an inflammatory process. They want to have patients stay off of their foot, which is great. Ice it, take anti-inflammatory medications, but that does not do anything to the underlying etiology. Now, one of the issues that's been proven with conservative care is that there's compliance issues, because patients don't always want to wear that big ankle brace, or they're not going to wear shoes with orthosis in them. So compliance is a major issue in treating this kind of disease entity. Yeah, and then, you know, one of the other things too that's extremely effective is putting people in a cast, because what that does is eliminate 100% the strain on the tendon. And just like most other structures in the body, if given a chance, if we eliminate the underlying etiology, then the body will be able to repair itself. So after 8 weeks of having this cast on their foot, you take it off, the patient's out walking, and life seems to be great. They're like, yes, this was a success, but it's only a matter of time until they come back and they say it's back again. And that's because nothing was done to address the underlying etiology. So again, they go back right here. So we had them in a cast, but now we have the naviculars dropping because the talus is just pushing it out of place because of the partially dislocating talus. And we have that repeated strain on their on the posterior tibial tendon. This is occurring thousands of times a day. So it's pretty brutal. Now, again, I don't have anything against foot orthotics, and my opinion is that if you wear shoes, you should have some kind of insert in your shoe. But the literature out there is not too favorable on the use of orthotics in treating posterior tibial tendon disease. And this is a paper that came out that showed that there was absolutely, it was an insignificant effect on the posterior tibial tendon. And the reason why that is and there's going to be some improvement, but it's going to be negligible because, quite honestly, an orthotic cannot prevent the talus from partially dislocating off of the calcaneus, and it's not going to prevent the navicular from dropping. So nobody ever takes an x-ray of somebody barefoot without their orthotic and looking at the alignment of the talus and the navicular drop, and then put the orthotic under their foot, or even take an x-ray with the orthotic in a shoe, and they cannot show how that talus has gone from a displaced to a realigned position balanced on the subtalar joint, or how that navicular that was dropped is now elevated. So it's just not, it's wishful thinking. And then we know that if we just go in and try to do a tendon augmentation procedure, that long time, that fails also because we still have the same underlying faulty foot structure. So that patient goes back to standing and excessive strain is now occurring on the augmented tendon until it fails. So the majority of people are told, just wait it out, wait till you can't take it anymore. And once that happens, then we're going to go in and do an osseous reconstructive surgery. And now we're going to cut your heel a couple of different places. I mean, obviously not everybody has this aggressive of a procedure, but it seems like everything is addressed except for returning the stability of the talus on the calcaneus. And yeah, a lot of times we're going to have, because of the long-standing recurrent tibiotarsal joint dislocation, the ankle bone instability, that patients will end up with a weakened first ray, posterior tib dysfunction. And again, we try to go in and cut the calcaneus and shift it in order to realign the talus and the calcaneus, but that's overkill, and that's a lot of complications and a long recovery. Some people wait even too long, and now their only option is to go in and have a triple arthrodesis. And so we know that there's so many complications associated with that. Their foot is never the same. It's improved as to what they first presented with, but at that point, that's the only option. And then there's other people that have waited too long, and now they need to get a pantalar arthrodesis. Obviously, a huge surgery, lots of potential risks, complications, non-union rate. I mean, it's kind of brutal, but it's better than an amputation. So that's why what I want to suggest to everybody out there is that we need to rethink this. And everybody talks about prevention and early intervention and all of those things, but very few of us actually act on that. So when this pediatric patient presents to your clinic, you know what's going to happen to them, because we see it with all of your other elderly patients that have that faulty foot structure and all of the different pathologies that they have presented with, not just posterior tib pain. So if we could have, in this pediatric patient, internally stabilize the talus on the calcaneus, this would instantly decrease the strain on the posterior tibial tendon, so that it would either help delay or even prevent them from ever developing a tendinopathy issue. Plus, we have all of the other positive things that will happen with the decreased strain to the plantar fascia and restoring the foundation joint to the body. So that's why something like HyProCure and EOTTS is such a very powerful orthopedic procedure. So think about what happens when somebody has that faulty foot structure and the talus is partially dislocating on the calcaneus. This is going to increase the strain on the tendon above that critical threshold until it then becomes diseased. So again, the tendon is going to be able, it's a very strong tendon, very healthy at this point. It's going to be able to withstand those excessive forces until they reach about that prime age of 45, 50 years old. And then at that point, the tendon is just given up. It can't deal with it anymore. And then we get those ruptures. So think about this. Think about the number of steps taken per decade of life. And by the time you're 40 years old, you've taken 72 million steps. By the time you're 50, 90 million steps. That's why this is the prevalence of posterior tib dysfunction increases as you get older, because you continue to walk, you continue to place those abnormal forces on the tendon until it just finally ruptures. Now, something else to also consider is once the tib post is being overstretched and it's weakened because the physiology of it is kind of not right. And so now what's going to happen is that the other supinatory muscles, like the flexor digitorum longus and flexor hallucis longus, are going to have to try to help compensate to prevent the pronation and to help supinate the foot. And what do we know that happens when the flexor digitorum longus contracts too much? Well, we end up with those flexor stabilization hammer toes. So that's all part of this faulty foot structure with the partially dislocating talus. The other thing too is the flexor hallucis longus is going to produce a counterforce against the first metatarsal head. So then we can end up with first MPJ disease, or also now we get the combination of instability at the first met cuneiform joint and usually with an increased IM angle, and then we have a flexor hallucis longus pulling excessively, and those forces are going from distal to proximal, so that's going to help push that first metatarsal bone even further out of alignment. So that's why this is a really complex disease process. So we have so many different things that are going on leading to that strain. So this study back in 2003 showed that it only takes about a 4 to 12% strain that will then turn a healthy tendon eventually into that diseased tendon. This is part of a cadaver study that I published a few years ago, and this is showing the strain gauge on the posterior tibial tendon as the researcher here was loading the foot, hyperpronating the foot. And you can just see how that strain gauge is being elongated. And all of that is happening because of the partial dislocation of the talus on the calcaneus. And these were the measurements here with the elongation. I mean, this one was almost at 9 millimeters of elongation, and the healthy part is only about 2 to 3 millimeters of a strain. So you can see with all the specimens that we have, they were about 4 millimeters all the way up to almost 9 millimeters. And as far as the strain, it said about 4 to 12% strain is going to be healthy strain. It's going to be okay, or that can lead to pathology. So what we see here at the 12%, that all the specimens definitely had above 12% strain. So that's why part of the study, then what we did is to show first what happens with the hyperpronating foot, how we have the pathologic forces acting on the posterior tibial tendon, and then we put HyProCure into the subtalar joint or into the sinus tarsi. And then what we showed was a significant reduction in the amount of the elongation of the posterior tib tendon itself. So let's look at these numbers. And of course, it makes obvious sense. I mean, this is like not rocket science here, but nobody ever published this paper and everybody wants to see these studies. So here it is. And this is back in 2011. I mean, this is almost 10 years old. We were able, in 10 minutes, popping in this sinus tarsi spacer to decrease the strain by 51%. There's absolutely no other way that you can have that kind of effectiveness while still having normal subtalar joint range of motion. So yeah, you can go in and perform a subtalar fusion, but now we have zero pronation and supination of the subtalar joint. So that's going to lead to arthritic changes proximally and distally to the subtalar joint. The other thing too, that there's a couple of things that happen that are decreasing the strain to the tendon. So number one is by putting in HyProCure and stabilizing the talus on the calcaneus, that then prevents the forces from pushing on the navicular, and that causes the navicular to drop. And so another study that I published showed how we elevate the navicular, we prevent navicular drop. So that's also then again another way that we stabilize the medial longitudinal arch with insertion of HyProCure. So this is the data from the study showing how we decreased the elongation force and the strain on the posterior tibial tendon by 51%. So that's pretty amazing. Now, we weren't able to completely normalize it in all of the specimens because, quite simply, some of them the tendons were so blown out that they had like more of a stage 2, stage 3, but we were still able to put a HyProCure in and measure a significant decrease of those forces. So some treatment is better than no treatment at all. And of course, it's going to be far superior than any form of non-surgical care. So the same thing with the strain. And that's why, sometimes we're able to, if it's a stage 1 posterior tib dysfunction, all the patient usually needs is a HyProCure alone. I mean, again, you have to take into consideration the other parts of the foot. But if they have a stage 2, like 2A, well, that's kind of pushing it. At that point, they're going to need to have a tendon repair, tendon augmentation procedure along with HyProCure, and they're probably going to need some other adjunctive surgical procedures as well. Yeah, so you have to know your limits. Every procedure has a limit, so we have to keep patient selection in mind when it comes to offering EOTTS in patients with posterior tib dysfunction. So you need to follow this criteria. We've gone over this. We have another webinar that you can look at that's in our doctor locator. And so with this one, with a grade 1 strain, there's obvious partial dislocation of the talus. We have pathological radiographic findings. And so with this person here, they only need to get a HyProCure. You don't need to do anything else with a grade 1. But with a grade 2, at this point, again, you have to evaluate the posterior tib tendon. You probably need to get an MRI so that you can really see what's happening in there. Something that is occurring now too is that a lot of surgeons will just go in, put in a HyProCure, open up the posterior tib, and just simply do like an augmentation or at least just kind of clean up any of the diseased tissue, use some stem cells in there, some amniotic tissue to help facilitate tendon healing. So that's a great combination. When we get into the later stages, again, this is where people are going to be kind of poor candidates for EOTTS. I mean, you have to know your limitations. This is somebody here that they have a negative calcaneal inclination angle, so we're probably going to have to do a posterior calcaneal osteotomy to fix that. They're going to need some medial column work for sure. So please don't think that you're just going to put a HyProCure into this patient's foot and you're going to fix them. That's where we're going to end up with a failure, and it's going to give HyProCure a bad name. So this is beyond really the limitation. And of course, if somebody's at stage 4, not a candidate. So for these people, this is where you need to do other forms of traditional osseous surgery. So anyway, we're kind of wrapping up here, but so early intervention is the key to any success. Let's catch them early. One of the things with supposedly the standard of care is that you're supposed to give this patient 6 months of non-surgical care before you even suggest a surgical procedure. And sometimes we really have to say, does that make sense in this situation? Because we already know that the literature tells us that conservative care is ineffective in treating this disease process. It's not going to help them long term. So why can't we perform a conservative surgical procedure where we insert HyProCure that is proven to decrease the force of the tendon to allow it to heal before we have to go on to more aggressive surgery. The other thing too that's so great about the HyProCure option is that we don't have the compliance issues that we have, that it's public, that's been published, that with conservative care. So once you put HyProCure into that foot, it doesn't matter what kind of shoe they're doing, what kind of activity they're doing, the strain on the posterior tibial tendon is being decreased. So in that 6-month period, this patient will take approximately another 1.5 million steps. So that kind of like doesn't make any sense to do that. We know that HyProCure is proven to have a positive effect. It's an internal option. It obsoletes the patient compliance issues. It's reversible. It's a conservative option. We know that it'll help to facilitate tendon healing. And what's the risk? The worst thing that can happen is that the patient doesn't tolerate the implant and if they have it taken out. But even after you've taken it out, or just as long as it's in there, we're still getting tendon healing. So there's absolutely nothing to lose. So what happens if we delay treatment? Well, we know that their foot's going to continue to get worse, and now we're just burying our head in the sand until more aggressive procedures are going to have to be given to the patient. So if it was my foot, I'd rather have a HyProCure put in than to wait and have more aggressive surgery with all of the long recoveries. So at this point, definitely want to go in and see if there are any questions or anything else. Please type them into us, and so that's great. And then if you have any other questions, please email us at info@gramatica.com, and we're here for you. If you anything we can do for you, just please let us know. Of course, if you want us to contact you, again, email us info@gramatica.com, and also to visit HyProCureDoctors.com. So thank you very much, and that's the end of this podcast, and we'll look forward to the next one. Thank you.